Hello, I'm Christiane Osypka-Boosfeld. Welcome to the first international webinar on electrical cardiometry in neonates. We are pleased that the invitation to the webinar has received such a great response. I would like to warmly welcome Dr. Stefano Martinelli and Dr. Ottavio Vitelli from Niguarda Hospital in Milan, who have offered to share their many years of experience with electrical cardiometry. We are also very pleased that Professor Daniele De Luca from Antoine Beclere Hospital in Paris has joined the team in Milan, who has been using our devices for many years. Furthermore, I would like to warmly welcome Dr. Silvia Martini from San Orsola Hospital in Bologna, who will present her experiences with EC in very preterm infants. Additionally, Dr. Yasser Nasseb, pediatric cardiologist and Vice President of the International Hemodynamic Society, and Dr. Hanan Farouk, pediatrician, participate in the meeting. Both are medical advisors to Osypka Medical. Many thanks to our partner in Italy, Fulvio Kais and Andrea Ricciardo from Webbit in Milan, who has been working with the clinical sites in Italy for many years. One short note: during the webinar, you can send questions via email to the address displayed on the screen below, which is cos@osypkamed.com. Thank you. We will then forward your question to the speakers. And now let's get started.
Thank you, Christiane, for organizing this webinar. Thank you to the clinical groups from Italy who are presenting today. And thanks to all of you for your interest in electrical cardiometry. Allow me 3 quick slides for a summary about electrical cardiometry before we get to the clinical applications. Electrical cardiometry is based on measuring thoracic electrical bioimpedance, and it is continuous and completely non-invasive. The compass screen, which you see here, which is part of the latest version of the iControl PC software, illustrates what electrical cardiometry is all about. Assessment of parameters which are indicative of the 3 components of stroke volume: preload, contractility, and afterload. And then stroke index or stroke volume times heart rate equals cardiac output or cardiac index. And unique to our technology is the measurement of thoracic fluid content, or TFC. The ICON electrical cardiometer works with an array of 4 sensors, A, B, C, and D. ICON applies to the thorax an electrical alternating current through sensors A and D. The voltage measured between B and C reveals, after some filtering or demodulation, the ECG and a waveform of thoracic electrical bioimpedance. What sensors should be used? EC sensors must meet more stringent requirements than ordinary ECG electrodes. Electrical current must pass through the EC sensors, which requires a more conductive gel than ECG electrodes. A less conductive gel may cause pickup of interference and compromise in signal quality. It's already a challenging measurement. We guarantee optimal performance only with the EC sensors. And most of all, your time is precious. I'm now turning over to the clinical applications.
Can you hear me?
Oh, sorry. Yes, we can hear you.
Can you hear me?
Yes, we can hear you.
Okay, so can I start, right?
Yes, please, if you can enlarge your, yes, that's perfect.
Yeah, thank you. So thank you very much for inviting me here. I'm very happy to share the experience about electrical cardiometry, which, as has been said, we have been using at the Paris-Leclerc University Hospital for, I would say, more than 10 years actually right now. And I personally believe this is a beautiful, very useful clinical and also research tool that has been too much ignored so far. We don't see it very much in our congresses, despite its accuracy, easiness of use, and let's say the quick turnaround, and the potential usefulness, particularly for units that do not have enough expertise in echocardiography and point of care ultrasound, which we have, and still we take advantage of the electrical cardiometry. I'm not going to go over this because you already listened to that. I just wanted to tell you that by the consideration of Bernstein-Osypka equation, and so the red blood cell orientation changes during the systole and the diastole, you get a lot of hemodynamic parameters. They are not immediately available, not even with point of care echocardiography. They are measured continuously, first of all, without practically any need for training. And it is true that there are other techniques that are able to give the same, but they are less suitable for neonates, and particularly for preterm neonates, compared to the electrical cardiometry. Now, this is a picture from 2015, published in our protocol. And as you can see, we've been using at the time the Esculon, the biggest screen over here. You can see it's a little bit old because some other, I would say, monitors are relatively old. But just to testify that we actually been using it since quite so long time. Now, obviously, we have the icon, let's say the smaller one, and else, and more easy to use. And here you can see one type of patient that takes advantage of the icon for, let's say, monitoring purposes, to understand without the sepsis workout if there is an initial change in hemodynamics before we go for a full point of care echocardiography or functional echocardiography, or is used also for research purposes in order to understand the amount of extra vascular lung water or the so-called thoracic fluid content, which is an important parameter. I'll say a few words by the end of my presentation. But before starting to use it, the very first question we asked ourselves 10 years ago was about the norm. Obviously, you cannot use any type of device, you cannot use any type of measurements if you don't know what is the normality, right? This is something we have been very often confronted in neonatology because there are still very black area of lack of knowledge. And so we did this prospective, very big study in order to draw, as you can see here, the nomograms of normality for the stroke volume and the cardiac output according to the different gestational ages and according to the different birth weight classes. Obviously, those were patients without any hemodynamic support, were just normal. And you can clearly see here the medians and the 25th and the 75th percentile that tells you more or less where is the normality. It was also interesting to note by the Bland-Altman analysis here on the left of the cartoon that there was a relatively good concordance between the cardiac output measured by the electrical cardiometry and the point of care ultrasound, although with a tendency to let's say underestimate by the higher values, and no effect on PDA and HFOV, although this has been not even reported in every single study, but we didn't find any particular difference in these cases. Then, since we have a huge transportation activity of more or less 1,800 transportation per year, we actually tried the same in our mobile NICU, and you can clearly see that there is also a good correlation between the stroke volume measured with the electrical cardiometry and with the ultrasound during the transportation, and basically the values are not changing before, during, and after the transportation. Now, there is another type of patients for whom this is very much interesting. It's not the stable or relatively stable patient when you want to do a workout before the full echocardiography and analysis, but it's about the patients that are already very sick. Here you see obviously a baby coming out of a perinatal asphyxia under whole body hypothermia with severe multi-organ failure and also extracorporeal dialysis. Or I don't know if I can, I put it another patient on somebody on ECMO. That's extremely important because even though in these patients we do a lot of echocardiography and point of care lung ultrasound, the fact to have all the values continuously allows you to pick it up what is happening in a concordant way with all the other monitoring systems. You can see here, for example, the arterial invasive pressure, eventually to saturation, and the near infrared spectroscopy. So again, to use the electrical cardiometry in these patients with multi-organ failure that already have a need for, you know, let's say, inotropes and very strong vital support, we needed to have the normality. We needed to know the normality. So together with the Niguarda hospital team in Milan, we have been doing this bicentric study in order to draw the nomograph for normality for the systemic vascular resistance. That's extremely important because these patients, they need norepinephrine. And exactly like it's done in the PQ world and in the ICU world, you want to have an idea of the systemic vascular resistance in order to titrate the norepinephrine, or ask yourself if its problem is not vasoplegia, but rather the need to increment the heart contractility or the volume filling. Now this is possible. As you can see here, we have colorful nomograms when you can clearly see different percentiles, and you see it's very well and nicely described by second degree equation. And on the top of the screen, you see that for in terms of gestational age classes, and on the bottom in terms of birth weight classes. And this is again the same, exactly the same thing for term babies. And you can clearly see how the maximal vascular resistance is a little bit lower in full term babies. And that's because with the patient growth, obviously the vascular territory grows as well, and there is a sort of a vasodilation while there is an increment in cardiac output that is going to compensate the relative decrement in systemic vascular resistance. This is something that was known in animals and very much concordant in human neonates as well. And in fact, as you can see here, there is a strict and quadratic correlation between the gestational age of the patient weight and the systemic vascular resistance. Again, those were normal babies. We did this type of studies just to help you there and have the normality at the bedside, and those are babies without any norepinephrine or any inotropes or nothing. But then, as I said, the tool is also useful to give you the extravascular lung water, which is something given in the PQ world by many, many devices, and we don't have any other to have this measurement in neonatal critical care. And for example, we've been using it also for research purposes, because as you can see here, this study that we published in Lancet in Clinical Medicine a few years ago demonstrated that the pronation on babies was useful for the lung aeration and oxygenation, but we also demonstrated by using electrical cardiometry that the cardiac output was not actually changing, and so the hemodynamics and the extravascular water were not exactly changing, so it was safe from the hemodynamic point of view. And again, on the extravascular lung water, that's very recent, has just been published on the European Respiratory Journal. Here you can actually measure what is TTN, transient tachypnea of the neonate, which is supposed to have much more lung water, much more extracorporeal lung water, because of the delayed reabsorption of excessive alveolar fluid. And you can clearly see here how these babies in orange, they have a higher level of extravascular lung water compared to controls. So this is a little bit very close to the clinical field, because you can eventually even use this one to have data, to have figures, to have numbers that tells you if a given baby has actually a TTN rather than Yali membrane disease due to primary surfactant insufficiency, as I will show you in a minute. And this is very useful because, as you can see from this graph, babies born preterm, like 32 weeks and below, the interstitium here in black is much wider, so it's able to accumulate much more fluid, and the alveoli tends to be, let's say, much more closed because of the surfactant insufficiency. In bigger babies at term and beyond, you see the interstitium is much more thin, so it can accommodate less water, which remains into the alveoli, which usually have enough surfactant. And this is why these patients are higher risk of TTN rather than RDS, contrary to the more preterm babies. And I urge you to refer to this paper, first authored by Dr. Neri, also to see a definition of Yali membrane disease and TTN based on this data, based on physiopathology, that can be very helpful for the clinical practice. And as I said, if it is true that there is more extravascular lung water in patients with TTN, it's also true that in patients that actually need surfactant, late preterm and term babies actually needed surfactant with RDS or with primary surfactant insufficiency, the water is the same as you can see here on the left. There's no such a difference. Conversely, there is a difference in lung aeration. So the alveoli are much more closed, and this is visible with the lung ultrasound. So you can clearly understand facing late preterm or term babies with respiratory distress that if the total fluid content measured by electrical cardiometry is the same, that's not a TTN. And if you do lung ultrasound and you see the lung is more closed, well, that's most likely RDS due to primary surfactant insufficiency. So the two techniques actually go along together very well, and they complement each other to let you understand much more in detail the respiratory pathophysiology, which we have not been able to understand very much so far just by looking at the chest film and on the clinical history. So we really need to thank to this technological advancement and Osypka for the introduction of this beautiful, completely non-invasive and accurate monitoring tool. I'm stopping here, but this is my email, and you can anyway write me for any question, curiosity, or willingness to collaborate. I will be more than happy to reply to you, and I'm also very happy to take all your questions. Thank you.
Thank you very much, Professor De Luca. Very interesting presentation. Maybe there are any comments from our group?
Can I just share one quick? Yeah, Professor De Luca, great talk as usual, really. It's been a while. I didn't listen to your talk. Brief, comprehensive, to the point.
Thank you.
As you said, I remember our last talk, like in Paris a couple of years ago, like the norms was the first step. We need to know where are the norms for those premature babies. And I was going through your paper of the norms, which you have it with Niguarda regarding the systemic vascular resistance after 72 hours and then 7 days. I'm really interested to look at the norms of all other hemodynamic parameters. If these data still existing, this could be used as a guideline for the normal range for this, because they have a very big number of babies. I mean, we can use it for scientific purpose if you all agree to have some sort of database for the normal range for all hemodynamic parameters for the guidelines. I remember in Taiwan, they did a couple of years ago only the norms for cardiac index, cardiac output, and contractility, 3 parameters only, but they used the first 72 hours postnatal. And I would say, if we can combine, even in future studies, multi-center, we can look at the Asian category and European, for example, maybe would be great as well.
Well, I can only tell you that you're right. Now, we have at least the reference curves for cardiac output and for the systemic vascular resistances. To be honest with you, we're now studying the ICON, the index of contractility, together with obviously the appropriate measurement at the point of care echocardiography. As far as I can understand, there are no, let's say, longitudinal, I would say, reference curve, as you said, which would be interesting. But to be honest with you, we lack such curves even for measurements done with other techniques. And even, for example, just for blood pressure, the simplest thing, we have very, very inaccurate ranges. So it's not so easy to follow them longitudinally, but at least we start to have them. And I dare to say that now we have even more data with electrical cardiometry than with any other technique. So one thing that we could do is obviously continue studying that, which we're doing that. And obviously the collaboration with the Niguarda Center is very fruitful because we can mix together patients. I don't know if Ottavio wants to say something about that, or Stefano, but we will also look in the very first window, the 72 hours. And the other thing that we could eventually do with you guys, I mean, from the industry, and it's not going to be very much expensive, we could create a sort of a small, I would say, like booklet with all the curves, with the reference data. So people that they have the machine, they can also have a sort of an atlas with all the data just to interpret them very quickly. That is going to be, I guess, very, very useful for everybody.
If I can add
Thank you so much. I really hope.
If I can add something, just a comment. During the study that we performed with Professor De Luca, we have obtained a lot of data from 10 newborn during the first 72 hours during the transition. So we will have also normal values of all the data, all the parameters during the transition, during the first 3 days of life. And this is incredible, and this is these are data that nobody has.
Wonderful. I mean, that's what's exactly my point. If you can have it as a kind of a booklet, as Professor De Luca mentioned, for scientific purpose, like for all other neonatologists, to be like kind of guidelines for this transitional period, which is really important. And again, knowing the norms for these normal babies would be of great value for everybody. Thank you.
Yeah, thank you so much for your comments. And I would like to forward now to Dr. Vitelli from Niguarda Hospital in Milan to give you a presentation, please. Thank you.
Can you hear me?
Yes, and we see your presentation. Maybe you can enlarge it. Yes, it's perfect.
Okay.
Yes, very good.
I'm Dr. Vitelli, and I'm here with my chief, Dr. Stefano Martinelli in Niguarda Hospital of Milan, and we would like to thanks Osypka for having organized such this beautiful meeting and to giving us the opportunity to share our experience with the ICON, which is a very beautiful experience. And I have to admit that ICON has saved us in several critical conditions, and I will share with you 2 critical cases that everybody I think has faced during his clinical practice. And the first one is a septic shock. This was our first article published on with the ICON, and I think that this was the first patient that we have studied with the ICON. And I will talk about Kevin, a 30 weeks of gestational age baby, born from cesarean section due to labor onset, and the mother received an appropriate antibiotic prophylaxis, and he underwent to steroid prophylaxis, complete steroid prophylaxis. And in day 1, he was on CPAP with the double antibiotic therapy, and he received surfactant at 3 hours of life due to increased oxygen needed. On day 2, it started to be more reactive. Apnea appeared. He reduced urine output, and blood gas analysis showed a very important acidosis, and his blood pressure dropped. So he was intubated. He received 2 bolus of saline. Blood tests were done, and the antibiotic therapy was changed with meropenem instead of gentamicin, suspecting a septic shock from a gram-negative bacteria. And once you face, every time you face an hypotension, you have to ask, is due to reduce cardiac output or reduce vascular resistance, or both are reduced, because you have to change the right inotrope. And this is what the ICON helped us to understand, because we put on the ICON and we saw a normal cardiac output with normal contractility, but very low systemic vascular resistance, considering the clinical picture and considering the age of our patient. So we choose low doses. We started low doses of norepinephrine, and we obtain a stable clinical picture with normal systemic vascular resistance, normal blood pressure. The urinary output started again, but 1 hour later, after started the antibiotic, he was still hypotensive. The systemic vascular resistance dropped again, but the cardiac index was normal and the contractility has increased. So we do not change our inotropes. We do not add another kind of inotropes because the problem were the systemic vascular resistance only. So we increased the dose and the vascular resistance increased, the blood pressure was normal, and through the days, with the amelioration of the clinical picture, we can reduce the norepinephrine following what the clinical picture was and what the data of the icon were, and we can suspend it after 2 days, the norepinephrine. And so the icon in this case helped us to early identify what happened when the clinical picture changed after the started of the antibiotic, helped us in choosing the right inotrope, and so allowed us to tapering also the norepinephrine through the days. This is another case, the management of the PDA, starting from a pharmacological treatment. We had a 27 weeks of age baby with an hemodynamically significant big PDA. And the icon says that his cardiac output was very high and his total thoracic fluid content was 44. Okay, let's say 44. We can say if it's high or is low. 44 in this clinical condition. After 2 days of therapy, the cardiac output significantly reduced, and also the thoracic fluid content reduced. On the 3rd days of therapy, we had the same values. This means that the no more days of therapy were needed because nothing changes from days 2 to day 3. So if you don't have an echocardiologist or someone who can perform an echocardiography to the baby during the therapy, you can follow the effect of your therapy with the icon through the days. And the effect of the paracetamol on the PDA and the reduction of TFC was also confirmed by the appearance of A lines at the lung ultrasound. So the amelioration also of the lung ultrasound was consistent with the reduction of the TFC. And I don't know how many of you are confident with the percutaneous closure of the PDA. We do a lot of procedures. This kind of procedure has less complication compared to the surgery, but also in this patient, post-ligation syndrome can appear. So you have to strictly monitor the hour following the intervention. And here you can see the icon inside the hemodynamic theater. The patient is monitored during the procedure, and I will show you the data of these 5 patients monitored before, during, and after the procedure. And each patient have different reaction, hemodynamic reaction to the PDA closure. In this case, in the exact moment when you close the PDA, there is a reduction of the cardiac output and the contractility with a little increase of systemic vascular resistance. But in this patient, these changes were not significant, and the patient was hemodynamically stable also after hours after the procedure. In this other case, we saw a drop of the cardiac output and the contractility, such as the other one, but there was an increase of the systemic vascular resistance. They doubled. So this increase of vascular resistance persists during the hour following the intervention, and the cardiac output remains low after the procedure. And this picture was in this picture we had also an hypertensive crisis, a huge and high, very high blood pressure. And how is it possible if the cardiac output is low? Because we have very, very, very high systemic vascular resistance. So we decided to start the Mirinon, and in 3 hours we can stop it because the systemic vascular resistance decreased and it became normal, such like in the baseline before the intervention. The contractility increase and the cardiac output increase. So after 3 hours, we can stop the Mirinon, and the patient was stable through the next days. In these other cases, there was an increase of systemic vascular resistance at the moment and the hour after the intervention, but after more or less 4 hours from the intervention of the PDA closure, the systemic vascular resistance spontaneously decreased and became to the value of the baseline without a decrease in the cardiac output. So we need obviously more study, more patients, but we can conclude that if you observe a spontaneous reduction of the systemic vascular resistance in 2 or 3, 4 hours after the intervention, and a normal cardiac output, you can predict a possible hemodynamic alteration. And I know that someone of you was interested in a newborn with hypoplastic left heart syndrome. I have to say just a few words. And this is a very useful, it's very interesting because in this kind of patient, you can't measure the cardiac output with the thoracic, with the echocardiography, because you don't have an output to measure. And otherwise, the icon measured the cardiac output at the level of the descending aorta. So this is the only way to obtain a cardiac output value in this patient. And I will show you 2 cases, William and Jada. William was stable since from his birth with a normal cardiac output, and he underwent surgery after 8 days of life. Jada was intubated. He needed a high dose of prostaglandin, and she has a very low cardiac output, even after the septostomy, which was not effective because the foramen ovale was the same before and after the therapy. So in this case, we do not put inotrope or something. We can follow the trend of our cardiac index, performing only an optimizing the volemic support. We change the ventilatory parameters. We make several bolus of saline, and in this way, the clinical condition gets better, and the patient was extubated the day after the procedure, and she underwent surgery after 8 days. So in these cases, this case was the only way. The icon was the only instrument that we had to monitor this patient. Otherwise, we don't know, and we can't know what was happening. So thank you very much, and I am open to your question if there is.
Yes, thank you so much, Dr. Vitelli. Very interesting. And I have one question from the audience. The email is, dear colleagues, I would like to ask the following question. Do experts believe TFC should be displayed by the icon monitor normalized by weight?
I think that looking at all the parameters of the icon, the TFC is the one that must be still studied better than the other one. So yes, maybe yes, because if we have something indexed for the weight is more precise, but I think that we have to do a lot of studies on TFC before knowing if it's better to have it indexed or not.
Okay, thank you very much. Any more comments or questions? Yes, sir, please.
I just want to comment on Dr. Vitelli. First, I would like to thank you so much for the wonderful presentation and the valuable information. I agree with you that the TFC, especially for the premature babies and the transitional period, we always see it high. And I like the idea when you present it, you said it's 44, we'll just leave it as 44. We will not say high or low. This is what we usually face. And I agree with you, maybe we need a little bit of readjustment for the premature babies, for the what's norm, what Professor De Luca said, what's norm for the TFC for that age group or that premature babies. That's number one. Number two, I agree with you very much about, again, when blood pressure goes low, we need to know, is it cardiac output or SVR? And for the case you had shared with us, we discovered that it's the SVR, the vascular tone is going down, so you start IBNF. But I'm interested to ask you about something which we are doing recently. I mean, we keep tracking the babies more frequently, and we could start to predict that blood pressure may happen in the near future than waiting for it to happen. Are you interested in doing that? I mean, will you be interested to kind of more predicting drop of blood pressure before it happens? And still we can easily, of course, know, is it cardiac output or vascular resistance or maybe IV fluid?
Yeah, of course. It's very easy because this can lead you to choose to know better everything, so to understand everything better. So it would be very interesting. Yes.
Great, thank you so much. I'll leave the mic for whoever have questions.
I have one question about the septic shock. Thank you so much for the lecture. It is very useful for us. About the prediction for the septic shock, as Dr. Yasser also asking for prediction for the hypotension. For the heart rate variability, there is a limited study about it. Can we ask for more parameter for early detection with the septic shock? As you know, septic shock is the most serious condition for the neonates. What's your opinion about it?
Heart rate variability is simple and very complex thing to understand, but I think that it will be the future. I know that Osypka is developed something about the heart rate variability that can help us to understand something about that. But I think that looking at the heart rate variability, we can predict lots of things, not only the septic shock.
Okay.
I have a couple of questions from different audience, but they are talking about the same issue, more or less. They are asking about the response for after PDA closure. As per the old guidelines, what we learn in the old time, that we expect after PDA closure, cardiac output will increase, stroke volume will increase, SVR will go down. But we came to learn later that it depends on the flow. Is it left to right flow, shunt, or pressure, high pressure, or right to left pressure? Based on your experience, especially with your paper, is almost like kind of 60-40%. Like 3 cases have increased and 2 cases have dropped in cardiac output after the closure. What would you expect the main reason for that? Is it the pressure variation what create the different response or other factors?
No, I think that it's for the difference of pressure, for sure. I think that it's also because the contribution of the shunt is there's no more contribution from the shunt, so you don't have the left-right contribution, and so the cardiac output decrease. And I think that is also let me say a shock for the heart to face this increase of resistance due to the closure of the PDA. Even if with the surgery, this shock is more important because the surgeon goes on the PDA and put the clip, and the PDA is closed. Otherwise, in the percutaneous closure, they go inside with the probe and they stay there. So it's a little bit more soft as closure. So I think that also the heart can get used to this new hemodynamic condition. So I think that is because also of these changes due to the closure of the PDA. Yeah.
Thank you so much. Thank you.
Okay, I think we will now continue. Or any more questions from your side? No. We are proceeding to the presentation by Dr. Silvia Martini from San Orsola Hospital in Bologna in Italy, and on her experience using ICON in very preterm infants. The audience is yours, Dr. Martini.
Thank you very much for having invited me here to share with all of you my experience with ICON. Let's just have a look at my presentation. There we go. Can you see it clearly?
Yes.
Okay.
You can enlarge it. Yeah, perfect.
Great. So nice to meet you all. I'm a neonatologist and a junior assistant professor at the University Hospital of Bologna in Italy. And I have started with my team to use ICON since 2017. And in particular, when we acquired the ICON, we started using in the context of a research project, which was the core of my PhD, where we performed a comprehensive hemodynamic monitoring, which included electrical cardiometry, near-infrared spectroscopy, pulse oximetry, and echocardiography to have a comprehensive overview of the hemodynamic status of preterm infants during the transitional period, which is the first 72 hours of life, as just said. So on the whole, we monitored nearly 200 preterm babies or very low birth weight babies, with the high hemodynamic instability, but also healthy. So we had the occasion to start checking at what kind of patterns were associated with worse hemodynamic outcomes. I would like to show just some of the results we have obtained from this research. And I would like to start with this paper, which has just been published in the European Journal of Pediatrics, where Professor De Luca is one of the main editors. And in this study, we aim to evaluate the accuracy of non-invasive measurement of cardiac output using electrical cardiometry and echocardiography in preterm babies below 1.5 kilos or below 32 weeks of gestation during the transitional period. And in particular, we performed a Bland-Altman analysis with calculation of bias and mean percentage error on day 1, day 2, and day 3 of life. In total, we measured 170 pairs of cardiac output values obtained with electrical cardiometry and echocardiography from 65 neonates during the first 3 days of life. And as you can see, the mean bias ranged between 8.3 on day 2 to 10.6 milliliters per kilo per minute on day 3 of life, which is quite a good value. As for the mean percentage error, which has a threshold of acceptability of 30%, actually our values were far below this 30% threshold, and in particular they ranged between 7% on day 3 of life and 7.5% on day 2 of life. So what we can say from these results, we can say that there was actually an overall good agreement and also satisfactory accuracy of electrical cardiometry in the estimation of cardiac output. And just to give some more information, the echocardiographic measurements were performed by a single operator. We also aim to evaluate whether some variables, for example, an hemodynamically significant patent ductus arteriosus or ongoing cardiovascular drugs, or also mechanical ventilation, may have an impact on the accuracy of cardiac output measurement by electrical cardiometry. We actually observed a slight but significant overestimation in the presence of an hemodynamically significant PDA, and in particular, the value was overestimated of nearly 17 milliliters per kilo per minute. And we also observed that the butamine treatment was also associated with a significant slight overestimation, nearly 12.5 milliliters per kilo per minute. We were actually surprised to find that when mechanical ventilation, and in particular different modalities of mechanical ventilation were assessed, there was no significant effect not only of mechanical ventilation but also of HFOV, which we know from literature that is association with reduced accuracy of electrical cardiometry is still controversial, because some data has reported poorer performance, while other data, for example, those showed by Professor De Luca earlier, are in line with what we actually found, that there was no significant effect. But I think this is a question that needs to be addressed by multicentric studies, because, for example, in our cohort, the number of babies on HFOV, which were included in this analysis, were very, 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 very few. So needs to be validated on further studies to find an answer. Let's move on to this other study, which was performed in collaboration with Professor Martinelli and Dr. Vitelli. And in particular, we aim to evaluate the predictivity of thoracic fluid contents and also of point-of-care lung ultrasound score, in particular BRAT score, towards the need of mechanical ventilation after 24 hours during the transitional period, but also towards the development of bronchopulmonary dysplasia at 36 weeks of gestation. We studied 65 infants below 34 weeks of gestation with a diagnosis of RDS in these two NICUs, Milan and Bologna. And we found actually that thoracic fluid contents values, and just let me do this note, in this case, thoracic fluid content was indexed for the infant's weight, so values indexed for the infant's weight greater than 40 were associated with a good sensitivity and an acceptable specificity with the prediction of the need for mechanical ventilation in the next 24 hours. While for the prediction of bronchopulmonary dysplasia, thoracic fluid contents indexed for the infant's weight showed a good sensitivity and a good specificity, and in particular values greater than 41.4 were associated with the risk of BPD development. We then checked whether the predicting performance of lung ultrasound score alone, TFC alone, or the combination of the two actually improved the predictivity of bronchopulmonary dysplasia. And we found that the combination of lung ultrasound score evaluation and thoracic fluid content evaluation during the first 72 hours of life was actually the best combination to best predict bronchopulmonary dysplasia at 36 weeks of post-conceptional age. From the same cohort, we also aim to evaluate the impact of a patent ductus arteriosus on thoracic fluid contents, still indexed for the infant's weight, but also on left ventricular output, monitored again with ICON during the first 3 days of life. Again, in this study, we also checked the lung ultrasound score, and we found that on day 1, 2, and 3, the presence of an hemodynamically significant patent ductus arteriosus was associated with significantly higher thoracic fluid content values and higher cardiac output values compared to infants with a restrictive or a closed duct. And these results were confirmed significant even after adjustment for gestational age and for the respiratory support modality, which we knew from the previous study could have an impact on thoracic fluid content values. Just to mention other studies we have performed using ICON, and these two studies were performed in 2020 and these 2024, and actually used ICON to evaluate differences, temporal differences in the context, for example, of apneas, bradycardias, and desaturation to check how cardiac output, heart contractility, and systemic vascular resistance on changed during these episodes, but also to evaluate the changes in the values provided by electrical cardiometry in relation to the administration of caffeine, which resulted in an increase, slight but significant increase of systemic vascular resistances. Finally, this is one of our last papers using ICON. We used ICON to identify different profiles in infants with different antenatal Doppler abnormalities, and actually ICON was very, very helpful because as you can see from this graph, it effectively detected different hemodynamic profiles in relation to the infant's characteristics. Finally, I would just like briefly talk about our clinical experience with ICON. After having used it in research for research purposes on preterm babies, we actually use to monitor, for example, babies after PD ligation, as Ottavio has just told, to monitor babies with hypotension because it is a really useful tool to get some information on the characteristic of this hypotension. So it is low cardiac output, high systemic vascular, how are systemic vascular resistances, and so on. And these can be also helpful to decide what kind of treatment could be better for that baby. And once that treatment has been decided, I think that also for monitoring the pharmacological response of this baby to the treatment administered, ICON is quite useful in this sense. I just end my presentation with this case report. This was a baby of 25 weeks of gestation with a birth weight of 825 grams. Born by an emergency C-section because of uterine rupture, very low Apgar scores. During the first 48 hours of life, the baby was quite stable. He was on CPAP, but at 48 hours of life, he developed metabolic acidosis, apneas, and hypotension because of the development of a grade 3 IVH. So this baby was intubated and put on mechanical ventilation, and in particular on SIPPV with the volume guarantee. And let's have a brief look at the cardiovascular parameters associated with the phase of hemodynamic instability. IVH was detected around this time, and the baby was very acidotic, metabolic acidosis, which was corrected by bicarbonates. As you know, metabolic acidosis can affect significantly heart contractility, and by correcting the metabolic status of these infants with the bicarbonates, you can see that there was a significant improvement in cardiac contractility. Afterwards, dobutamine was also started to support the heart pump, and also because of hypotension, and you can see here a slight increase again of heart contractility, but the baby was still hypotensive. So we commenced dopamine at the starting dose of 3 micrograms per kilo per minute, which you may think it's such a low dose, but you can see from this graph how this led to an increase of systemic vascular resistances. And systemic vascular resistances increased further when dopamine was increased at 5 micrograms per kilo per minute. However, as you know, a raised afterload may affect cardiac output. In fact, let's have a look at cardiac output by the time that SVR increased, slightly decreased. Thank you very much for your attention, and this is my email address for any kind of question or contact. Thank you.
Thank you so much, Dr. Martini. Very, very impressive presentation. And we have more comments or questions from the audience. So maybe, Yasa, you can continue on that, please.
Thank you so much, Dr. Martini, for your wonderful presentation and sharing these interesting cases. I have different questions. The first question is from Dr. Jasmine from Malaysia. She said, thank you so much for your talk and Professor De Luca talk as well. And she's asked, is there a specific timing to measure the TFC? And is there a difference between the first measurement of TFC after initiation of respiratory support before or after? Did you notice that?
Yes, it was a slide that I hadn't shown, but from our study, we saw that the TFC values decreased with increasing days of life. So they were higher on day 1 and lower on day 3. And in babies who required mechanical ventilation were actually higher than those who didn't have this need. But after the babies were put on mechanical ventilations, these values tend to decrease, probably because of the effects of mechanical ventilation on lung aeration and the fluid clearance as well.
Right, thank you. One more question from her as well, Dr. Jasmine from Kuala Lumpur, Malaysia. She said in her study, she found that vaginal delivery had higher thoracic fluid content compared to normal delivery. Did you notice that as well?
Sorry, was vaginal delivery compared to C-section? So she found,
yes.
Okay.
So having high TFC in vaginal delivery, but it come back to normal within 3 hours.
Okay, so we actually haven't this kind of information because most of our preterm babies that we analyzed were born by C-section. So in this case, the majority of them had a C-section and we didn't analyze this kind of variable. It could be interesting to check, and I think it would be also nice to know why she monitored the babies born by vaginal delivery. I would like to ask, were they like asphyxiated babies or with mechanical aspiration? What was the reason why she performed the monitoring in these babies?
Okay. As far as I know, she's doing observational study, big one. I can connect you with her later on via email. If you don't mind, then probably you can have the conversation. One more thing she's recommend, which I recommend too. We would love to have
something about. Can I add something about?
Sure, yes, please, go ahead.
I've told you that we have a lot of data from term babes during the first 3 days of life, and talking about the TFC, we have seen that baby born from vaginal delivery had a higher TFC compared to the vaginal and to the cesarean section. Yes. We don't know why. We still have to look at this data, but we also have this. We don't have the reduction. We don't see the reduction in the first 3 hours. Because we have a little bias due to the skin to skin, or when we take the measure. Obviously, we perform it as soon as possible. But if the baby was in the delivery room with their parents, we did not put the icon on, so we leave them there. So the first measure usually was obtained around 5 or 6 hours of life. So, but we also have we also see that the vaginal delivery has an higher TFC compared to the cesarean section.
Thank you so much for your addition. I mean, Dr. Jasmine is listening to us now, and I'm sure she's assured that she's not the only one noticing that. Her last recommendation, which I would add my voice to it, that we would love to have normalized range for TFC, either indexed or normal value for premature babies. I would believe every neonatologist is interested in that. That's from the audience questions. I have one question for Dr. Martini, if you allow me to ask quickly. Regarding the overestimation of the cardiac output with the hemodynamically significant PDA, do you think that overestimation happened because the icon would measure the aortic flow, which may combine some of the pulmonary flow, but the transthoracic echo we use, it measures only the left ventricular contents? Do you believe that the variation comes from this factor or different factor?
So it's just an hypothesis because, of course, I have this kind of thought, but I couldn't actually verify if this is or not. But in my opinion, it could be also because I read some other papers, previous paper who had the same hypothesis. It could be because of the interference of the ductal flow in the icon measurement of LVOT or LVO value. Because you know, the ductal position can vary across babies. So actually we don't actually know, for example, in that baby we're monitoring whether it could impact or not the flow measurement.
Perfect. Thank you. Thanks so much. One more question. We have it here from Dr. Lin from Taiwan. She said that, as you said, although the guidelines say that the high frequency ventilation, the icon should not work, but she agree with you that when there's nothing else to use, she put the icon and sometimes it just works. And with it correlated with other technologies, the data is correlated. So what would you think about that? I mean, I know you tried only on 3 cases. Shall we do like a more bigger study on that?
I think that since this topic is still controversial, there are different results in literature, it could be worthy to go more in depth to try to understand what other variables can affect the accuracy and reliability of icon measurements during HFOV. Because, for example, in my experience, and I think also in the experience of Professor De Luca, this is not significantly affected. In clinical practice, as I mentioned before the start of this meeting, in some babies, the signal is more artifactual than others. So perhaps it could be worthy to check if there is something that perhaps we can improve to improve the signal during HFOV.
Thank you so much. Thank you.
Okay, any more comments? We have received, 2 questions from Chile in advance. And the first question is, do you prefer to use cardiac output and SVR, so the systemic vascular resistance, indexed or non-indexed? And the second question would be, when cardiac output and SVR are measured, what ranges or normal values do you compare it to?
Okay, shall I respond first?
Yeah, it would be nice if you do it, or if anybody else has some comments on that, would be nice. Thank you.
Okay, so briefly, in my opinion, in my experience, I tend to use both cardiac output and systemic vascular resistances indexed for baby's weight and for the body mass index respectively, because I think when we are talking about preterm babies, they can be more reliable.
Mm-hmm.
Yeah, I agree with Silvia, because indexes are more reliable, are more precise, and are more tailored on the baby that you have you are monitoring.
Yeah, sorry, it was body surface area. I said BMI was BSA.
BSA, yes. Mm-hmm.
Yeah.
Okay. Mm-hmm.
I have one question for Dr. De Luca, please.
I'm not sure if he's still in. Yes.
Yes, I'm here.
Okay, thank you.
Okay. About the fluid responsiveness educator for the children, for the neonates. Yeah, you have a paper before with Dr. Boyd about the stroke volume SVV as a parameter used for the fluid responsiveness detector for the neonates. Did you use another parameter? Because we have another parameter which is flow time corrected. Also, we are using it for detection of the fluid. Did you manage to use this parameter also with SVV? As SVV, sometimes there is limitation for arrhythmia, ventilated neonates. Did you use this parameter before?
It's easy. It is not clear in the critically ill neonates which parameter should be preferred. That's an endless discussion, even in bigger patients, like in adults. So you can use this one, as you said. You can use the other. You can also use some other that are just measured by functional echocardiography. I personally, at least for me, during my night shift, I look to all of them. And so I adjust accordingly. I I don't give any actual preference to any of them. I look a little bit to all of them, just because there is no data to prefer one over the other. However, we must also recognize that if not all data are available and there is just electrical cardiometry, I do believe that just using the stroke volume variation with electrical cardiometry is way better than nothing. And that must be very, very clear, because sometime outside you can hear somebody saying, well, okay, but you don't know, it's unclear, it's not enough accurate. But since the alternative is nothing, well, nothing is much more inaccurate. So
yeah. Okay.
I mean, Dr. De Luca, thank you so much. I mean, to be honest, I learned this statement from you many years ago when you said, look at the whole picture, look at everything. And this is what I'm always teaching to my younger colleagues. Don't just look at SVV only or FTC only or changes in stroke volume over time. Look at everything. Keep watching everything, and you will catch something. And as you said, the alternative is nothing. It's either you look at everything and learn, and then you can even get your own prediction algorithm, your own learning curve. You know that this baby is going to have this sooner or later based on watching the parameters changing. Thank you so much, really.
You're welcome.
Okay, so thank you so much. I think we have come to the end of the webinar, and thanks to all of you for taking the time and contributing your expertise and knowledge to the audience. We are pleased that EC can make a valuable contribution for optimizing therapy in small patients, so please keep up your great work. I would like to share, let me see, one screen with you. Okay. I hope you can see that. And so we are planning, the next webinar will be scheduled in about 3 months, and it's about case studies only. So you are cordially invited to present a case of your own, and please reach out to me if you have any interesting case. Thank you for listening, and we hope to see you soon. Arrivederci, and thank you so much.
Thank you.
Ciao. Thank you so much.
Thank you.
Thank you. Bye-bye. Ciao. Bye-bye.
Bye.
Bye-bye.
Okay, bye-bye. Take care, and thank you so
Bye-bye.
much.
Thank you so much for all of you.
Mm-hmm.
Thank you.